All right, who'd like to start leading off with a question and get some discussion going?
You look at Vern's plan of care and it's multimodal, it's addressing all these different areas, it's addressing barriers. I don't think cannabis is ever gonna be the answer for intractable pain. If it's going to be a part of a patient's treatment plan, it might be one aspect of a multimodal, broad plan of
I
care.
think you captured really what I wanted to present, which is how complex and multifaceted chronic pain is, how enduring chronic pain is. To think that one treatment is an answer is, of any treatment, it doesn't matter, cannabis or anything else, is just on the face of it, wrong.
One of the reasons I asked you to go back and display that DARE scoring is, I think we probably need something like a DARE score, maybe not that exact scoring, but something similar that could be used as an assessment or qualification for a patient that may or may not be a good candidate for medical cannabis. If they've tried everything else and they have all these other social issues going on in their life and they're looking for cannabis is going to be my answer to my pain, that's a fallacy. It's not the answer.
I'm thinking of all the patients who I see who are smoking marijuana, and they're pretty miserable. Of course, I wouldn't be seeing them if they didn't have, ongoing pain.
And you're also making reference indirectly and in the direct where you address it, but I wonder what perspective you have on chronic pain versus suffering. In other words, the relationship there, and you talked about it plenty, the relation between body and mind, and so on, but I think it would be very important to keep those two terms, which are very interrelated, in mind. What do you think about that?
I think the first thing to point out is that they are different. Just last week, I saw a patient who was paraplegic from primary progressive MS, and he had severe neuropathic pain. But you could tell he's going to be fine. He's not letting it control him, and he's not suffering. He's just would like to see improvement if he could. And then other patients who have pretty minor pathology, they may be suffering 10 times as much as that guy. So they're separate. I think that's the main thing I would say about it, is that they are two separate things.
I don't doubt that when we see the literature summary that there'll be benefits that were palliative for a lot of patients, but maybe not so much improving their functional status
Yeah.
with chronic pain.
That would, I think, be an important thing is there an improvement in function? That would be an important outcome to look at.
I'm sure they'll look at it. Sativex is about a 1-to-1 combination of THC, cannabidiol. I would hope that we might get some summary of Sativex, which is approved in like 24 countries now, Canada and Great Britain, as far as what benefits maybe they've seen with that approved pharmaceutical product.
Some of those are in the literature review that our office did, and it's on the website. For MS patients, mostly because GW Pharma, the
That's the
manufacturer,
only approved indication.
was trying to commercialize for an MS indication. It is approved for some other things, but that's where there's quite a few trials, which are of somewhat longer duration and they're a little larger. A lot of the trials that are done, our clinical trials, are very small and very short duration. I can't remember if those have physical function or function measurements. I think a few of them might. I have a question that's very broad, but try to answer it if you can. Obviously what we do in this country to address pain isn't entirely working because there's still people who are suffering. And so why is that? What is the lack? Is it a lack of the modalities, the drugs and the treatments to take care of the pain? Or is it the lack of how our system is arranged so we don't get the right
can address the multiple facets of pain, including, to some extent, suffering. In my clinic, we have recreational therapists who bring joy back into activities. And so, but insurance in many clinics isn't going to pay for that kind of thing. They're not going to pay for programs that help people just sort of gain control of their lives through their own efforts, which takes some time and some money. So I think that's part of it. But then I also think we don't really have, we don't have a silver bullet. We would like one. And there are some partial silver bullets, I think, coming down the pike. Because now this glial cell activation is showing promise. And I think it might help reverse some of the fallout from chronic pain. But even that, you know, there's just, like I was showing you, every level of the nervous system gets impacted. And it's, you know, it's like trying to solve Iraq or something. It's not easy.
I'd like to make a comment about that because I treat kids, and what you see is pain in children sometimes is a representation of what's happening in society a lot. I have kids that will present because of homelessness. They don't want to be in the shelter. They have a chronic illness, but they are really well. But they present to the hospital because it's a safe place, and they see pain or medicine or needing to be in the hospital as a way to kind of get their needs met. And they do get their needs met at the hospital, right? But we have child life therapists. They get 3 hots and a cot. They have people that care about them. They have people that they trust. And so if that cycle gets perpetuated into adulthood, how are we to prepare them to be self-sufficient if they see the healthcare system as part of their family, so to speak?
Yeah.
And if medicine is their ticket to get that, then it's a challenge. I have many children because I practice in an urban setting who present because their home isn't safe, or there's food insecurity, and so I think chronic pain for those kids can start early, and it's really hard to transition them to an adult service. Because even if I've been working with them for 10 years, maybe I still haven't fixed the underlying issue that they don't have a trusted adult. They don't have, their parent may be a user of substance. They don't have any way to sort that stuff out. So for kids and adolescents who come into that chronic, and then you guys all see them down the road, I've probably already been working on it for 10 or 15 years, and like in a kid with sickle cell disease, there's usually, it's multiple levels of complexity.
And some of that's probably entrenched in the first 3-4 years of life.
Yep. Yep.
If not the first 1 year.
Exactly. I mean, if they experience a medical trauma where they were really sick and almost died, then you have this PTSD component. There is a fear of death, and Miles is right. I mean, in our clinic, we do have a multi-level, but we operate off of a $1 million foundational subsidy. That's the only way we can keep our doors open. $1 million benefactor dollars a year is what allows us to keep our doors open. That's how much insurance doesn't cover.
Is there a correct me if I'm wrong, but is there a shift in how insurance companies are pinning clinics and hospitals when you get X amount of money for X patient versus fee-for-service type thing? Is that shifting, or is that going to be shifting, do you guys know? Because they talked a lot about that with the integrated care system, where they would have like social workers
They
right there,
have
and
care
like right in,
systems,
right, where you get like $3,000 for this client, or for this patient, you do, here's your $3,000 for this patient, take care of their needs.
It is coming to adult healthcare systems, inpatient primarily.
Okay.
That's where they're gonna target first.
The problem is we did it in the 90s, only we had a name for it. What did you call it back then? HMOs, yeah. I'm denying now. You can't, or capitated systems. You
Right.
can't use that. So what you're talking about is a capitated system by a different name, which
Right.
still makes sense.
But that's what they're moving towards. or they're trying to
They
encourage
want,
it,
they
right?
keep trying it.
Okay. Because that's just gonna make things more difficult. Hard to know. I mean, versus fee for service.
But capitation aside, is there any sort of movement towards paying more for the multimodal sort of care? Because that's part of what I'm hearing is that's part of the
Yeah.
challenge is that.
Wasn't
money-
that what Obama was trying to put forward? I think so.
I think in certain funds, yes, there is. You know, I know in chemical dependency, there are certain funds, you get increased funds for certain services and stuff like that. But in medical setting, I mean, you really, what you're talking about is that whole integrated care system, where it's not just the physician who's working on it for 10 to 15 years, there's a team. And a team of people work together, so it's not, because that young person is gonna get maybe not comfortable in the medical setting, but might be comfortable in an institutional setting, which is gonna be the revolving door of the judicial system.
We're seeing pharmacy provide MTM or medication therapy management in an outpatient setting and not always getting paid for that specific service, but as part of Fairview is an integrated healthcare system, so to help reduce the overall cost of that patient's care, it's a benefit, it's a proven benefit.
Miles, I have a question I'm a little uncomfortable with because it feels pejorative and I don't mean it that way. One of the contributing factors you listed was personality disorders, and the studies I've seen show that 30 to more than 50% of patients with chronic pain have a personality disorder.
Right.
It may not be their fault, but it still makes it much harder when they show up at our clinics to provide care for them, and we know that makes it harder with opioids, and I guess first you have a comment on that, and second, how might that then apply to what we're looking at with cannabis?
Yeah, I mean, personality disorders are formed early, and they're enduring. What makes it hard is because by definition, it's harder to communicate with somebody with personality disorder. It's difficult to have a meeting of the minds and communicate. And some personality disorders, by nature, are anti-rule, and they don't feel rules are made for them. And so you could ask them to comply with a certain treatment. If it doesn't suit them, they're not going to. So that's a big barrier. And then the second part of your question is, oh yeah, how might this apply? I think it applies to every potentially high-risk treatment. Surgery, for example, opioids, everything that carries some risk or that requires a good communication between the caregiver and the patient is hampered by that kind of problem.
How are we at, or what do you guys are aware about, like, naltrexone, the opiate blocker? How does that, or receptor, how does that work with have you used that with some of your chronic pain individuals?
I haven't.
Okay.
I know there's a study, at least one study, looking at it in pretty high doses, I think, for fibromyalgia. I haven't used it. I know there are some studies looking at the plus isomer of naltrexone as a glial cell inactivator, which looks very promising because it doesn't reverse opioids that are analgesic. So that would be kind of interesting. And you probably know it in terms of use for what, alcohol dependency?
Well, it's used with, we're using it more as anti-craving for alcohol, but also for chronic pain.
As a treatment for
As a
that?
treatment for that, but also with buprenorphine for Suboxone, Subutex, treatment of heroin and opiate addiction.
In addition to the naloxone that's in the,
Well, it's naloxone and buprenorphine together makes
yeah, right.
Suboxone. Yes.
But not naltrexone, right?
No, but they're using that also. The naloxone is the overdose that they're actually
so that if it gets injected, you'll save a life, you won't lose a life over it, hopefully.
Yeah.
So, I think one common denominator in terms of how we sometimes do poorly with chronic pain treatment is that we don't have the long view in terms of really helping people address the underlying issues, and that can be challenging for a variety of reasons, whether it's payment or the structure of care or whatever the thing is. But I think it's also, as a society, we haven't really, we like to have a magic bullet or a fix, and sometimes it's really a long struggle instead of a quick fix. And I know that, in chronic pain management, part of it is really getting someone to buy in and just really get religion about their treatment plan, get really engaged and participate in an active way.
And to let go of that quick fix,
Yeah.
that search for the holy
Change that
grail.
mentality. So one concern I hear sometimes about both opioids and cannabis is that they may actually prevent people from engaging really actively with those more effective approaches. And I'm just curious what your thoughts are about that, or if you've had any experience with patients
I think
that could be helpful.
That is true. I mean, a lot of these drugs have some dissociative properties, so that you lose the motivation, and there's a sort of a neurogenic apathy, if you will, that makes it unnecessary to find a better solution. And it's easy to kind of go along, not great, but getting by, and over time, you get by with maybe a little more of the medication or treatment, and pretty soon, you're kind of miserable like you were before, but you're maybe more apathetic about it. And so I think that does happen I see it happen with opioids all the time, and I don't know about cannabis because I don't have any experience with that. But I'll bet you any dissociative, I see it happen with other drugs, even antidepressants.
It's passive coping versus active coping.
And some patients who are the extreme example, I've had quite a few over the years, just beg to have me knock them out for 3 days. Just knock me out. I know it's all I need is 3 days, and I'm going to be better for 3 years after that. I won't ask you for anything else. Just knock me out. And that's really what they want. They want to be knocked out. Because when they're not knocked out, they're pretty miserable. They're suffering. So the question is, should we knock them out? I've always said, no, I'm not going to knock you out.
Well, I know from, medical marijuana is very different than, recreational marijuana, and you get the purpose and the ideas of it, but it's used in both ways. But I also do see the other side of it is there's too much prescription of opioids, right, out there, and too much diversion of the opioids. And whether that's diversion because young people are taking grandma's pills, or because doctors are prescribing too much, who knows? I know one gentleman who was on 300 milligrams of gabapentin, and then they raised him to 1,500, couldn't figure out why he couldn't walk the next day. Well, 3 to 15 is quite a jump. So there's got to be a lot more holistic care, and we have to look at the social, emotional, physical, and spiritual piece of that when we're trying to encourage this care.
Something that I hear occasionally is the hope that using medical cannabis for pain will be able to allow patients to reduce or eliminate their opioid medications. And I've taken a bit of an interest in this without knowing anything coming into it. I'm trying to look to see what sort of literature there is, and I'm not finding too much. Some anecdotal reports. I'm wondering if you have any observations. I know that you're not primarily meant to address the medical cannabis part of it, but since you're here, do you have any any observations to make on that?
Well, I guess my experience with people who use cannabis is that they're as likely as my patients who aren't using cannabis to, maybe more likely, to want to continue their opioid medication and continue it at the same rate.
Sure.
I don't have too many patients saying, you know, I started smoking marijuana and you know what, it's really working for me. Let's taper off the opioids. In fact, I can't think of any who said that. So, you know, I'm sure there are cases like that, but I haven't seen them.
Just as a corollary with the e-cigarettes currently, which is also controversial and there isn't much research, but there was a study that just came out in veterans showing that, you know, those who started e-cigarettes with the hope of quitting smoking were less likely to quit smoking than those who didn't start e-cigarettes at all, you know. So sometimes people hope for a substitution, but that doesn't occur. Of course, that is not, I don't think there's any data on cannabis and opiates, but I think often the hope exists, but
Yeah, it doesn't seem like there's too much real study of it.
I mean, one way to look at it might be, have the prescriptions for opioids gone way down in Colorado, for example? Have they? No.
although it's tough because I think they've started to level off and go down in a
Yeah,
lot of places
yeah, yeah.
because there's been a
Like the whole
simultaneous
country is
policy
doing,
change.
You'd have to try to see if there's a trend that's different from the general.
You know, our new director of pain and health partners made the observation for his patients that have chronic pain, he thinks the way that opioids work, many is not so much that it affects their actual pain level, the somatosensory part, but their way of responding to it, the affective part. So you're not really reducing pain, you're just changing a response. Does that sound?
Yeah, I think that's probably true.
So it's not really helping the pain, it's just helping the suffering.
Now, maybe it's also helping the pain
Yeah.
too, but
Yeah.
what's obvious is that it does, it seems, opioids anyway,
Yeah.
and patients tell me this, the pain's the same, but I don't care as much about it. Those are quotes from patients, a lot of them. So they can see the difference. Pain score is the same, pain's in the same place, same distribution, but they don't care as much.
Is that a reason that they consider using it?
I think in some settings it would be like a palliative, you know, end of life. Yeah.
Or as a bridge to recovery, you know, if they are willing to be more functional for a period of time.
Yeah, although it's hard to get them to because the
Yeah.
motivation
Exactly.
isn't there.
Yeah, and I think I would have to agree with you, of the patients that I treat, that I know or find out they're smoking marijuana. It has, actually, I think it makes them more opioid seeking because they want more and more to check out. They just slowly lose their desire to participate actively in their life.
And some of the effects of the opioids are as anxiolytics, that anxiolytic effect. A lot of patients probably take it inadvertently to control their own anxiety, their mood, to control their mood as opposed to really using for pain.
Right.
So is that a correct use of medication? That's also for question.
Yeah.
And then
Is it more apt to be a useful anti-anxiety agent than a pain agent? Maybe. And is it safer than, say, benzodiazepines for management of anxiety?
So use them both at the same time. So and regarding the question about the cannabinoids, allowing for a lesser amount of opioids to be used, in other words, to be able to control pain. Really, when we treat pain, there are three basic things that we look for. One is to decrease the amount of pain, for sure. Two is to decrease the amount of medications used for pain. And three is to increase the level of activity of this individual. so that they can be more functional and be able to enjoy their hobbies, enjoy their job, enjoy their family, be more active, more productive, hopefully, as well. So that would perhaps be also part of what our conversations are going to be about in the future. How would cannabinoids impact those three areas? And there are probably more.
Yeah. Like measuring quality of life.
Mm-hmm.
And we're getting back to the other thing about will they reduce their opioids? I have a parallel thing with that is that I often see patients who are on oxycodone and hydrocodone and sometimes a long-acting morphine. And I say, well, why would you be on two short-acting medicines? And they have an answer. And the answer is usually, well, I use the hydrocodone because it helps my headache, but I use the oxycodone because it helps my back pain. And oxycodone doesn't help my headache at all. If anything, it makes that worse. But the hydrocodone doesn't help my back pain. So you've got, they're on opioids, but they're not willing to give up one of them. They're hanging on to all of it.
Our commissioner talked about a task of comparing or deciding if it's safe and effective, and I don't think making that decision about cannabinoids should be tied to whether or not they're gonna replace opioids. You know, it's better than opioids. I don't think that's the answer that we say, well, it's better than opioids. I don't think that's answering the question that it's safe and effective. And that's something we gotta keep looking at that big picture, making a decision.
Having said that, if I knew that I could get a patient off opioids by giving them cannabinoid, I would probably take that change in a heartbeat.
Yeah, as long as you have faith in
Faith that they
the
could actually do it.
cannabinoid that's being used,
Right.
consistent and
Right, but I mean, if it was a trade-off, you wanted the other.
What do we know about that? And maybe I just need to go and read this literature, but I don't know what medical cannabis can offer the pain patient, in addition to what all the other meds that are out there are doing. And I agree, it's not realistic to think that we're gonna be able to introduce, and so people are listening to this as a medical answer, and that all of the other bad things that could potentially add up and be bad will go away. I'd like to think that, but human nature is they're gonna keep their safety net. My biggest worry for chronic pain patients really is their level of self-destruction. And ultimately, it's their suicide risk on these dangerous substances. My job is keep looking at a taper. Just keep your focus on doing no harm. And I don't know what medical cannabis is that going to potentially create harm? Is it really safe? Is it in the long term? Because chronic pain patients aren't going to get a cure from it. It's going to be a long-term thing. Right?
Right.
And, you know, the other thing is, how do you diagnose chronic pain? It's really all subjective. There's often no findings on Our Lady here had didn't have a lot on the scan, but it's subjective. Whereas it's not subjective diagnosing multiple sclerosis or glaucoma. So that's a hard one, is sort of verifying the diagnosis.
That's why I struggle with the intractability piece of it, because if you say there are no treatments available, and if you apply that to Paris, there are. She may say there is nothing,
Right.
there's nothing
Yeah.
available.
I tried that. I've been there.
I tried
I've
that,
done
I tried that one for 2 days, and I tried that one for 4 days, and I tried this for 2 weeks, and
Yep.
I took that once, and they write everything off, but yet you know that if she would really persist with her psychotherapy, really process her strong emotions that she has never done, and really find something in her life to focus on where she got joy and pleasure from, that she would. The chemicals in her brain would literally start to shift.
You'd certainly hope so. And at least there's room
There's
for
room to
recovery.
try, and trying for 2 days I always tell the kids, I'm like, nope, you have to agree to try for 30 days. We're not starting anything unless you try for 30 days. But, so I can't call that intractable. I just can't, because I can still see things that have been suggested and are viable options that I know are successful.
And how many patients have jumped through all the hoops so that you would basically
Right.
drill down to the one thing that's left, which is say opioids.
Right.
That happens all the time.
Mhm.
And, you know, they've read the textbook and they've read the law and say, okay, I gotta do PT, I gotta do, you know, and then they go through the list, they do them all. And now I'm ready for the next, what's the next thing, doctor? What's
Right.
gonna be stronger?
Right.
And so that's a tough one, that you don't have, there isn't anything objective. And you're judging motivation to recover and to function better. It's hard.
You can do it.
What is next? So we'll do this spinal cord stimulator.
Mhm.
We'll do a pain pump.
Why'd you point to him when you said?
Why?
No. Oh.
She's pointing globally.
Okay.
Theoretically.
No, I'm just kidding.
Maybe we have had, I have patients in mind already that I'm hoping medical cannabis might be in the discussion for them, but I also, it's not a slam dunk, it's not an easy to A, B, and C, and if none of those work, then let's intractable pain, by the way, when I hear that, immediately I think of PTSD, because I think it's part of the package. With pain that persists longer than 3 months is chronic, longer than 3 months in a day could potentially be intractable. And that's traumatizing for a lot of these people, especially if their premorbid personality functioning isn't very robust. It's not one of the, you can't get medical cannabis for PTSD yet.
Not in this day.
Not in this state, but potentially we could be
Other
having
states.
another forum like this for that.
Well, and when you look at some of those, mental health disorders, if someone has a mental health disorder or an illness, they may be more hypersensitive to physical pain. They may have those,
Yes.
you know, so they're gonna feel that.
Yes.
When she's got PTSD, she's gonna feel that pain a lot more than the other person does.
I could
So-
guarantee you that the Paris, if you did a functional MRI and did a great stimulus, would have a amplified response in her brain compared to London.
Whereas other people would look at that and say, oh, she's drug seeking. Wait a sec, I know.
Well, I know my chronic pain patients, when they have a flare, it's not because they had something physical happen, it's because they had something emotional.
Absolutely.
And that very same thing does put people at increased risk for developing a substance use
Yep.
disorder with
Absolutely.
repeated exposure to a substance, whether it's iatrogenic because we prescribed it or it's, recreational.
And the
They're
stress
in a
level.
vulnerable state.
Mhm.
Right.
Oh boy, what do we think to do?
This is the concept of adverse selection that, that Mark Sullivan has documented with opioid therapy, and that the people who are the least likely to benefit and the most likely to be harmed are the most likely to receive opioids and to receive higher dose, higher risk regimens. One can imagine that the same thing could be true here.
Miles, you've been doing this for 3 decades. Can you tell a patient really has pain or not?
I just believe them. I believe they have pain. But then I see it as my job to help understand where the pain is coming from, what are the contributing factors. So I try to interpret the pain for them, but I believe them. But then I don't just leave it at that. So it's different than Margot McCaffrey's definition of pain, which is
The pain,
pain.
what the patient says it is.
Yeah. Pain is whatever the patient says it is, wherever they say they have it, and to whatever degree or whenever they have it. Which I think is doing the patients a disservice. Why do they need, what's the doctor for?
Right.
What's the pain specialist for?
We have a duty to provide a medical recommendation.
Yeah, you as a patient, you're the expert on what you're feeling, but then I have to be an expert on how to interpret that so that we can come up with a strategy.
Right.
You're also the salesperson to sell along that strategy at the same
Yeah, a little bit.
I mean, it's about motivational interviewing, getting them to realize that they to decide that, yep, this is what I wanna do, this sounds like a good course of action. When you guys, when you get a chronic pain patient in, do you guys look at, metabolic, vitamin levels, all that other stuff to see? Okay.
Yeah, not religiously, but you know, there are certain things that we know play a role.
Cause I'm just saying with the correlation of depression and, you know, chronic pain and stuff like that.
Yeah.
Just want to watch your time a little bit. I think this has been a good conversation, but I just want to sort of see where folks are at. I'm going to make the assumption that there's not going to be any public comment unless you would like to. I don't want to close the door on it, but I just want to play with that 15 minutes.
I wouldn't mind just saying something really quick.
Okay. Let's leave that in the loop. Do we want to continue on with the conversation here for a little while longer? Do we want to move to public comment? What's our choice?
Well, I think we're probably coming to the end of the.
I'm all
Yeah.
for,
Okay.
Answer that. So-
Okay, then let's open it up. I just wanted to get a ring to the group. If you would like to make a comment to the group.
Sure.
Get some time. I would
Oh, no, it's gonna be
appreciate brevity and also not repeating yourselves.
Yeah, of course. My name's Cassie. I'm from Minneapolis. I would just say I've actually been in remission. I have Crohn's disease, which is obviously quite different from chronic pain. But I've been in remission for 6 years exclusively on cannabis. So I would just really urge you guys, based on some of the statements that were made, to keep an open mind and don't necessarily assume that everyone on cannabis is lazy and unmotivated. I literally would not have graduated from college, wouldn't be working, would probably not be sitting here living right now without it. So I would just really urge you guys to put your assumptions at the door and open up to the possibilities of medical cannabis, because I think they're really a lot broader than you might even realize.
Additional comments? Would you? Okay, good.
My name is Curtis Hanna. Thanks for having me here today and for having this discussion in general. I think it's very healthy for the state of Minnesota and people that have intractable pain. I did want to quickly mention that the human body currently has an endocannabinoid system, and it was already mentioned briefly that that system does produce a substance, anandamine, which is very similar to THC. And if, as it was suggested, anandamine already is a substance that is providing pain relief, and correct me if I'm mistaken on that, it seems like a very easy step to make, to say that a substance that is very similar to anandamine, THC, would also be something that provides pain relief for the human body. And it could be the case that certain individuals do not have a properly functioning endocannabinoid system, and therefore they don't produce enough anandamine in order for the body to naturally have this pain management. And the question is whether those individuals should be able to supplement the amount of anandamine type compounds within their body with a supplement which is derived from a plant that has not been known to produce any overdoses that results in death. And contrasting that type of plant with the opium plant or synthetic derivatives of opium, it seems like, frankly, a no-brainer that should be something that individuals that are in extreme pain ought to have access to. And currently, I do want to point out that under the Minnesota cannabis law, there are only pills, liquids, and wax or oils that are available. Any of which, if you were to possess as a patient that has intractable pain, that would be a felony under Minnesota law. Even one pill that has a mixture of THC in it is a felony. So the decision before you as a body and the recommendation that you're making to the commissioner is whether patients that have intractable pain that perhaps get one pill, well, currently they can only get it illegally, but should they have the legal right to be able to access these pills or these oils or these liquids and not be branded a felon because they're trying to take care of themselves? And I think that it's a fundamental right of human right, that we have the inalienable right to life, to not do what we can to preserve our bodies, to liberty, to have the freedom to choose what sort of substances we put in our bodies, and the right to happiness. Because honestly, if you have intractable pain, as it already has been gone over, it results in depression. And so I think the metaphor of the shorter time to arriving was perhaps a apropos one, in which there's a lot of people that are suffering in Minnesota. And I ask that the people on this panel decide or try to be as empathetic as possible, to reduce those opaque walls, to be one with the other rats in the cage, and to have some empathy and to listen to the stories that are out there, because people are using this substance currently in order to get pain relief. And I think that if you go into this practicing good listening skills and advertise the fact that these meetings are going on, that you'll hear stories of individuals in Minnesota that really need this for relief. And I just ask that you have as much empathy as possible and practice that empathy as much as possible, and not just to look at medical studies only, but to really do this job as a full human being. So thanks again for having these public comments.
Appreciate it. Next steps.
Well, I think our next steps are to reflect back on responses to what is the one thing you'd like to learn or have to help in the discussions and deliberations that we'll eventually do, and to see if there's anything more now than anyone comes up with. And if not, that's fine, even in coming weeks and months. If you think that there's some product, something that would be helpful for you or for the group to have, let me know. We'll do what we can to try to provide it and get it to you. I think there's already some things up here that we'll think through and see what we can send as an information product.
We touched a little bit on the other states. We at least put out a definition of intractable pain. That there was another one that I noticed that we touched on just a little bit. Anything else to add? And I don't want to open this up wide to think about it.
Sort of
yes.
implied here, but a lot of what you put together is, does it work for these different conditions? And that's what's primarily on the website for the evidence. Even though it's illegal to do that therapeutic research in this country at the moment. What we do have some research on, I think, is more what the deleterious effects are. And that I haven't seen listed, and that would be really helpful for us, because frankly, I think part of what you said is, if it's not dangerous, if there's not a risk, or if the risk is not as much of an issue, we're going to get to a much more light.
There's a big body of research from recreational use.
Right, and I think that's where we at least have to start. And for example, I'm much more worried about its use in adolescents and young adults than I would be in an old person like me. But although I'm not planning.
Right, if you look at how most of complementary, alternative, or integrative medicine practices, the standard we use is how much could it potentially hurt somebody, and if we think it's at least safe, most likely won't cause harm, then most people feel pretty comfortable recommending those things. And how kind of how they're graded and judged is, if we know it hurts and we're not really sure that it helps, then people are less likely. So
There's certainly a lot to draw on.
And maybe just some
Before we go on, can I just
Sure.
say something? I just wanna thank the people back in there because, I was expecting a much more, difficult, but you guys were both, I thought, measured, and one came up with a scientific component to it, and the other one came up with a personal but measured, presentation of your own experience, so we got lucky.
Yeah, well, thank you.
Yeah, thank you.
That was very logical, fair-minded. All right.
Yeah, other options or other sort of research pieces maybe send Tom? Makes sense to send them to you, any other
Yeah,
thoughts on
other
this?
ideas of things that would be
Yeah.
helpful for the group.
Okay.
The only one thing I would wanna just add to that is harm reduction. Looking at it from a harm reduction perspective, which one's worse?
Say more.
Harm reduction perspective, which, if they continue with this medication, or they continue with this avenue, or they continue with this one, which is the lesser of the evils for them, for their life, for their environment? Do they have a safe environment? Is it a place where it's gonna be diverted? Do they have a supportive environment? Do they have, good, are they coming to their appointments? Are they seeing, doing all those other things? It's gotta be that holistic, but it's also that harm reduction piece of, what is the effects of all the opioids on the kidneys? Versus marijuana, especially the disease.
Sort of the same idea of, giving out clean needles.
Absolutely, absolutely.
Even if you don't necessarily believe in the, substance, as therapeutic, you wanna reduce harm.
Right, and if it means that they're maintaining their life or improving their life, are they able to function, on a safer level, we have to consider that too.
So I think what we'll do is we'll take away these ideas and anything else anyone comes up with, and see what we can do within the next few weeks to come up with some things to start giving you. So even though we're not gonna have a meeting till September, I think there's probably gonna be quite a bit of information type products sent out for your reviewing. So there'll be things to keep doing. And on your own, you can think through, and as you talk with your colleagues, and start thinking about, lots of issues have been raised now. Well, what might this group actually do to try to come up with some sort of a recommendation?
And we'll have, the Office of Medical Cannabis post any materials that are being disseminated on the website, so everybody can get to see what we're looking at.
You mentioned the three articles.
Yeah.
Yeah, are those in the review that you can?
No, these are literature review type articles. Would that be helpful to get sent those citations? Did you include that on the?
Okay. Anything else? Any other comments or questions? The next meeting, to be scheduled sometime in September is going to be the public comment, primarily public comment. Sounds like there's also going to be some presentation.
Kaufman group then.
Right. We'll sort of mix and match.
And maybe something else. It seems like there's something else that would be really helpful over the next couple months.
Okay.
Thank you. This is what I want to say to all of you for your time and your interest in energy. It's going to be an interesting adventure ahead.